going to get started. Welcome, everybody, to another episode of Interop Workshop. Like I said, we start on time and we end on time. This is a technical discussion of all things related to healthcare data exchange and with the goal of facilitating interoperability overall. I stand by it. I say it every time for those of you that show up all the time, but I promise you this will be the most fun you can possibly have and still be talking about healthcare data exchange. And if you heard Dave and me going back and forth beforehand, that's the kind of humor you'll find with the rest of this. It'll be great.
And three wheel just dropped.
See, right there.
Well, they shouldn't have, because Dave is funny.
And this is going to be great. And a little wild too. Normally I have control over these things. That's not a chance on this one.
Yeah, no.
Not at all. My co-host here, I'll give her that kind of billing for this, is my better half, and also my partner in this, the president and co-founder of Zen Healthcare IT, Marilee Benson. She's for those of you who may not know her, that's too bad, but she is a SME in the data exchange use cases, national networks, and a whole bunch more. She said she's going to be a good contributor to this one. And quite honestly, she knows more about FHIR than I do. So that's
nowhere near how much Dave knows.
Oh yeah, oh yeah. And I'll be giving a much better introduction and detailed introduction in just a minute. I'm gonna do a little housekeeping first. But Dave Pyke is joining us here today. So Mike, excuse me, Dave, I'll hold on to the mic for just a couple of moments here, and I will get right back to you after we do a little housekeeping. As I think those of you who have been here before, I want to shout out to Karen Flaties, the director of marketing at Zen, that helps me extensively in putting these things together behind the scenes. She doesn't get credit unless I give her, and she deserves it. So credit to her for those things. The way that we do this, again, for those of you who haven't been here before, this is a real world discussion on interoperability challenges, and we invite clients, prospects, vendors, and yes, even competitors to join the discussion. This is an open mic forum here. We do ask, turn your cameras on, turn your microphones on. We'll turn you off if you get, if the kid comes in the room in the back and starts screaming at you or something. But we do like to have it interactive, and as you'll see, we encourage you, reasonably so, to interact and interrupt and ask questions, because this makes it better for you. So don't be bashful. Turn your cameras on, and if I recognize your name, I may call on you anyway. So at least know where the mute or the unmute button is, because it happens. It happens quite often, as a matter of fact. So, and I reserve the right to do it. We will be monitoring the chat. I hope that you will all open the window for the chat. I'll be asking you for different things from time to time. We will be posting links there that are worthwhile for you to know. So please open the chat. And if you're too bashful and won't ask a question, you want to ask it in chat, go ahead. We'll be monitoring that as we go forward. Additionally, in the chat, I encourage you all to introduce yourselves and the company that you're with. You may be surprised at others that you find that are like-minded with you or otherwise, and you want to at least introduce yourself and have others know who you are. You do it if you want to, but you never know when a good connection comes from doing that. This particular episode always has a sponsor. Sometimes the last one was sponsored by an external company, and that was really great. This one is sponsored by Zen's Command Center, and if you're not familiar with Zen's Command Center, it is really quite new. We're just rolling it out, and has lots of features for it, including a brand new version of Zen Insight for the integration engine. And no, you don't have to be hosted by Zen's Zen's infrastructure in order to use it. So if you have any interest in that, again, throw it in the chat. We'll be glad to reach out to you. But we thank Command Center for sponsoring this. I think lastly, before we get into the real meat and potatoes here, we do have lots of sessions. We've been doing this for pushing 3 years now, 2.5 years. We started early 24. There we go. Thank you for Mandy. Thank you. We started in the early part of 24. Here it is, 26. So I guess a little over 2 years of doing it. We do have the sessions on YouTube as well. Karen, if you do get an opportunity for that link, throw that into the chat there. If somebody wants to search what those previous episodes were, there's actually some really good ones out. Actually, I think all of them are good, but there are certainly some that are still relevant today and cover a lot of different topics. So I encourage
None
you.
will be like this one, we promise.
Exactly. Exactly. Finally, we do want to make sure that this is being productive for you. We're taking an hour out of your week, or you're investing an hour of your week into doing this. I think this one will be very entertaining and informing good information for you. But we always invite you to put topics as well. If you'd like us to get a good guest and dive in more, throw an idea out there. We'll be glad to research and find the best guest that we can possibly talk into joining us for an hour and have a little fun with them and get some more information. So that's how we do it around here. Glad to see the faces that have joined us, and welcome to everybody. This particular episode, what I put the catchphrase that was out here, that somebody yelled fire in a crowded theater and the CCDAs didn't make it out. I kind of thought it was funny, but it's okay. But we'll cover it in more detail here. So as I get ready to introduce our guest here in detail, FHIR. I mean, how many people, ready to show our hands, how many people know exactly what FHIR stands for? Dave does, Mary Lee does. Look at that. Okay.
Jeff does.
A couple of folks don't have their cameras on, but we do. Michael
knows.
For those of you who don't, FAST, Healthcare Interoperability Resources. That's great. A little history on it, and Dave will certainly correct me. Started out as draft standards for trial use. One was in 2013. Yes, that was 13 years ago, 2013. The second version of DSTU was published in 2015. The third one dropped the draft and became the standard for trial use, version 3. They're in 2017. You're noticing every 2 years. It's in their releases. That's great. Release 4, R4, 2019. There again, 2 years. Then the ONC comes around to 1 year later and includes it in the final rule for the 21st Century Cures Act, and R4 is on the map at that point. So there's the history behind it, and our special guest, who I am getting to here right now, will correct me and add to those things. This gentleman is the vice chair of the HL7 Technical Steering Committee. He's the technical director for the HL7 FAST initiative, and that's basically how to implement FAST at a FHIR at scale. He's a technical advisor to TEFCA, that little organization that orchestrates everything for the national networks in the QHEN. He's individually authored a large percentage of the HL7 papers and data and ONC documentation on FHIR. We'll put a link out to a number of those resources here in a moment in the chat. Clearly, he's one of the top healthcare data standards architects, and as you'll meet in a second, he's certainly the best one that would be willing to come on this show for this, and he's also a lot of fun, which so he's an interoperability nerd and fun, which makes him a perfect guest for Interop Workshop. Please help me welcome Mr. David Pyke. Dave, thank you for joining Interop Workshop.
Yes, as Dennis pointed out, Graham was not only there, Graham invented it. Um, starting off as resources for healthcare, which was a far better name, but it was taken. The URL was taken, a lot of things. So we settled on FHIR. Actually joined in the fray as part of the QA team for STU1, DSTU1. The reason it dropped the D is because HL7 dropped the D altogether. Sounds different than I intended to say that. HL7 stopped using draft as part of the name because it confused people. And then, of course, we've had R5, which you conveniently omitted. That was released about 2 years ago, and R6 is in final balloting. It should go into its fourth ballot now, so that we could actually have a normative version, meaning a version of FHIR that will be backwards compatible forever, starting probably next year.
Fantastic. And if that is the only mistake that you correct me on this show, it will be absolutely amazing. And we'll probably, yeah, I won't take that further than that is. So let's start with some basics here, because we're going to get into some real meat and potatoes here, which is why Marilee's here, because I can't keep up with you guys. But simple question: what is FHIR?
Um, that's a simple question. I don't want to hear your complex question.
Okay, give me the simple answer of the elevator pitch of what is FHIR.
FHIR is what we should have done years ago. What Graham did, and with help from others, Lloyd and Hewitt, said, what could we do with an exchange standard if we took everything we knew now and put it into play? So by the time 2013, really 2011 rolled around, OAuth was in place and JSON was in place, and all of these things that were commonplace that simply didn't exist when, CDA was created and the IG standards came out, and certainly not when V2 was created back in the Stone Ages. So we want to take what we learned from HL7v3. No, most of you probably have not heard of HL7v3, and that's a good thing. So take the data structure ideas, take the fact that we wanted to make everything into really just a piece, what we call a resource, which has very specific data on a very specific element of information, right? An operation, a condition, a patient, an event, that kind of thing. Yes, CDA is what's left of V3. Dennis, you don't have to tell people that. They didn't need to know.
It would have come out anyway.
It would have come out anyway. So break it down so that originally we were trying to do something for mobile, right? Because you wanted phones to be able to download somebody's record, and phones didn't have 128 gig or 256 gig or a terabyte of information space. They had 150 meg. So do something that a phone or tablet could do, so you could really see as your, health record a little at a time, right? Don't need to download the 10 meg CDA file. Don't need to download 800 V2 messages. Never want to download 200 V2 messages. So take that, break it down into these small JSON formatted structures called resources, make it available through RESTful exchange, so the same way every website works, and make it so that it was fast, efficient, interoperable healthcare resources. Wait, that's a great name, FHIR. We could call it that. And that's where we started, right? And again, I was in the periphery, right? It's Graham, it's Ewart, it's Lloyd. They were the ones who were doing the heavy lifting. They're the ones who were pushing it through. I was simply there going, I'm sorry, this failed QA on 15 reasons. Here's my 140 something comments. And that's what created. That's why, when we went to the first Connectathons, right? And I missed the first one. I was at the second. People are sitting there and able to create an app to get healthcare data in a day, where, anybody who's ever looked at a CDA document and tried to make sense of it knows that, I'm sorry, if somebody sends you a CCDA of any sort or a CDA of any sort, discharge note, whatever it is, it's a very complex document. It has all kinds of things that don't, reference easily. It has all kinds of custom codes. It has all kinds of that just make it impossible to do efficiently. So let's throw what we know into the mix, what we know is new and efficient and fast, and make it into a standard where I can ask for, hi, I need all the encounters that happened on March 31st or later for this patient, get just the encounters, and then say, okay, well, obviously I need the diagnosis that came out of that. Okay, go get those. Or I need the observations that came in. Okay, go at those. So you're getting the data as you need it, when you need it, not here's everything for the past 5 years or 25 years all at once. You figure out what you want. And when you stop screaming, you can, read the
Right.
screen.
So you request what it is that you want at a particular time.
Yeah. You say, and it's literally a web query, right? So the same way you go to Google Maps, right? You go maps.google.org/map/, and that will give you the map for whatever location you're interested in, right? Do the same thing for healthcare, right? I don't need the map of the world. I
Right.
need the map of this city, or better yet, the block I'm on to know where that store is. So do the same thing in healthcare. I don't need the patient's entire record unless I ask for it. I just need to know what happened on March 31st and everything that came from it.
So great. I need X pieces of information. That's what I'm interested in getting in, near real time. But back when this was, you're talking about 2013, circa, give or take a bit there. You didn't have national networks. You're still doing it on a point to point to point to point basis, are you not?
We're still doing that now.
Yeah.
Most connections, if you look at the national networks, FHIR use is in its infancy. And that's because, well, quite frankly, there is no parts of it that scale easily, right? It's a point to point. That's the way FHIR was designed. So you need security that scales to as many as possible. And that's what the FHIR Scale Task Force, what I'm technical director for, has been working on. We started off as an ONC project, and then ONC got tired of our crap, kicked us out, and made us a FHIR accelerator at HL7. They said something about we don't invent standards, we adopt them. That was a weak excuse. They couldn't get us out the door fast enough. I should talk to him one of these days. It was good for my reputation. No. And so FAST came up with what we call scalable security for registration, authentication, and authorization, which was based on the UDAP standard, which if you are in the TEFCA world, they call SARA, and I will never forgive them for that because we call it fast security.
That was going to be one of my questions I had down there. Okay, where did that one come from? Huh? Okay.
Uh, well, if you do SSRAA, security for scalable registration, authorization, and authentication, as that gives you a very weak SARA. You can ask Jason Voigt where it came from because he started it and he still owes me a beer for it, and I will never forgive him.
Is he on this call? Come on, get
No,
somebody.
he's not. He's in a meeting.
Oh, he's in a meeting. Okay. Okay. Now you've covered a lot of territory there. I was actually going to try to limit you, but you were on a roll and it was good, so I let you go. But you jumped, and I don't want to make sure that everybody's following along.
Okay.
FHIR is still point to point.
Yes.
Okay, great. Well, we got national networks, which augments that a bit, but you're saying it's still point to point with the national networks because I'm querying a national network and it's a hub and it's going out, whether it's using an EMPI or querying the world or what have you, and saying, hey, give me whatever you got. And those point to points are coming back together and it's still a point to point. Do I have that right?
Well, sort of.
Okay.
Now, if you look at the national networks, they're all based on CDA exchange, right? CDA documents,
Yep.
because that's what everybody supports, right? Unless you're a critical access hospital working with software from the previous century. So that's the basis from it, and that's how they work for that, right? You query your connection, your QHIN, right? Qualified Health Information Network. That QHIN queries all the other ones saying, who's got information on James Benson? They come back, said, we've got lots, but you can't have it because some of these things should not be published. Or better yet, say,
Hey, PHI.
I wondered how long that would take. Anyway,
That was slow.
and they said, those that have it because the members of their individual networks, right, their participants have information. They come back and said, we've got data on James Benson. What do you want? And that goes back to the originating requester who selects, I need these 5 discharge notes or this CCD or whatever's available. That's how that works. Right now sorry.
Oh, sorry, Dave. Finish your thought.
Okay. In FHIR, it's going to be very different because FHIR, it will always be point to point. There is no way to emulate that whole workflow in FHIR. It is possible. I worked out a couple of years ago with the help of some others, possible ways of doing it, but it's really inefficient. It is much better to have the QHINs facilitated. And that's why under TEFCA, they call it facilitated FHIR, where they know where the information is, so you don't have to query the entire network for it. And they can provide you, hey, here's the FHIR endpoints that have information on James Benson. That means you, as thing, then go directly, uses the certificate issued by TEFCA, using the SARA IG, to each individual, get what you want, right? So if it's, go to this major hospital because there was, he had an operation there. Go to this clinic because he got, something small done there. Go to their, private personal care physician because, they did this medication, that kind of thing. So that gives much finer control. And again, you're not getting the entire medical history of the patient. You can say, hey, he was at this hospital between this date and this date. Give me everything between these dates. Or more importantly, just give me, what observations were made during that, or give me what the condition was. Much simpler, much faster, but still point to point, which is okay because rarely do you need everything, right? Even as a clinician, they rarely need everything. They need something the past 5 years at most.
Okay. I want to be respectful here. Dennis, you got your hand up, brother. Give us a question.
Yeah, I turned my video on, but the light, it's sun shining here. I'm in Canada.
Sun shining here too, can't you see?
Yeah. So, dual citizen, American, U.S., originally born in the U.S., came to Canada 20 years ago and stayed here.
And well on his way to recovery.
Yes, yeah. So first of all, I was CTO of Canada Health InfoWay for 14 years and developed the concepts that are in the blueprint there around a shared health record. So
on his way to recovery.
Yes, the first thing I have to do is challenge a statement you made. FHIR is not necessarily point to point. Our model is not point to point here at the provincial level, where it's a shared health record, and it could be populated and queried using FHIR, but that's another day for another conversation.
Okay.
One of my key questions for you, as you were talking about this, and knowing there are extensions in FHIR and the like, how often would you say a query is successful? And what I mean by that, I know I'll get something back, but will I understand what I get back because of those extensions? And will I be able to use all the data I got back? I'm just curious as to, on a scale of 1 to 10, how would you rate FHIR? We dealt with this with Z segments. In Canada, we call them Z segments. And when I was on the Fresh Look task force, we did clearly say we wanted to, at all costs, avoid those extensions, if you will. It obviously didn't work, but that was many, many years ago now. So just curious what your thoughts are on that.
Excellent.
On a scale of 1 to 10, I give it an 8.
Okay, fair enough.
Against the CDA, which I give a 4, and a
Yeah,
V2
fair
message,
enough.
which I give who knows.
Fair enough.
The extensions, if something's properly published, then the extension should be ingestible. That's why FHIR extensions are written in FHIR. That's why FHIR implementation guides are written in FHIR, because everything should be ingestible. In most cases, if you get an extension, it should be attached to a FHIR implementation guide. In most cases, which means somebody has gone through, worked out exactly what the workflow is, figured out exactly, and published somewhere saying, hey, if you ask for a patient in this context, it will come back as part of this profile, which you can ingest the whole FHIR IG and build information around it. That being said, you will at least get the basic patient information, right? That which is part of core FHIR.
Sure.
When Canada ever publishes CA core, that will give you more context because those will be core extensions for the Canadian environment. I'm Canadian. I should mention that. I didn't mention that. This is not
I knew that.
where I am.
We've met before, David, a while back, though.
Yeah, I know we have. I just, but there are people who don't know that, I'm of a superior race.
Hey,
and,
you are Canadian, eh?
Hey.
Hey. So yeah, I had to learn the extensions on speaking in Canada. Eh?
That's it. And you have to say Z segments because that's the way it's properly pronounced everywhere else in the world.
I love Z segments. And I have two things. First of all, Dennis, I think it's a great call out about the aggregation that can happen. I think in the US, the corollary would be our regional health information exchange that often aggregate data, and they can make data available via FHIR. So, that kind of, we have a similar situation there. Yeah.
Yeah, I'm familiar with some of those. Yes.
Yeah.
That's a great call out too. Yeah.
And then Dave, the other thing, just because we're talking national networks right now, you mentioned it's all CDA exchange, and yes, except for, because there's always an except for, TEFCA and individual access services for Epic specifically. And
not just Epic.
Yeah. Well, and not just Epic. That's right. There's more coming. There's more that we're starting to see FHIR endpoints for. But one of the things that you and I talked about recently is that SARA is that facilitated, TEFCA implementation guide, but not everyone is using SARA yet, and Epic specifically isn't. So I don't know, maybe you could comment on that.
Absolutely. I mean, SMART was published in 2019, SMART on FHIR, which is the profile on OAuth and OpenID Connect that is effectively the standard for healthcare FHIR exchange security. The problem with SMART, and the only problem with it, it's a wonderful standard and I support it wholeheartedly, is that it doesn't scale. Because the first step in a SMART exchange is a manual process, right? You have to send an email or call and say, hey, I would like access to your data. Which means that can take anywhere from 10 minutes to 10 years to get the first step, the client ID. Once you have that, then SMART makes it easy, right? Take the client ID, go through the SMART process, you're on and up and running. But the minute you put a human process in it, that breaks scalability. And that's why fast security is born.
That's a real thing for IAS under Epic right now.
Oh,
yes,
yeah.
it is.
That's happening.
Right now, that's exactly right. Using SMART, you can connect to Epic instances through TEFCA using the TEFCA IAS exchange purpose code and get your data. But that's one at a time. That means your app has to connect to each individual access point and go through the manual process to register. So care quality and ONC work together to create the fast security guide, and that takes away that human step. It has what's called dynamic client registration, which means through TEFCA or care quality or Commonwealth, you get a certificate, and that says I'm a soldier in good standing. I will be a good person. I will not steal all your data and sell it off to the highest bidder, or at least I won't admit to doing it.
And that's the business aspect that that we talked about before, where you're doing that to be a participant with it anyway.
Yeah.
Okay.
So
that's how treatment works.
Right.
That's how
essentially, because you get a certificate.
Yeah. Well, everybody doing FHIR will get a certificate, right? Whether it's IAS, treatment, payment, whatever use case. If you're doing FHIR, you will get one of the certificates once you've signed all the terms of participation. That certificate plus what's called an OAuth software statement, right? Which outlines who you are and what the software is and what likely scopes. So what types of information you're going to request. You take that and you do a dynamic registration. You just send it in. It says, "Yep, got it. It aligns with good practice. Here's your client ID." Once you have that client ID, you fall through the same OAuth things at all. It's been slightly profiled and extended by FAST and by UDAP to allow for more information, like user information, like organizational information, like patient information. If you want to say, "Hey, I'm the patient. Here's all my demographics to prove I'm me," that can be added to it the way that OAuth can't, because OAuth was really designed to be a simple, fast extension. Once you have that, they accept that, you get your authorization token, away you go. You start doing as many FHIR queries as you can, before you get rate limited.
Right.
And I see Brian's comment, welcome to the trust framework.
Yeah.
That's it.
That's right.
Hence the first word in TEFCA is trust.
That's right.
Okay. We're going to change gears just a tad because we're going to come back to this, and you've blown my flow entirely. So
good.
Well,
You've done our job, Dave.
You didn't give it to me in advance. I get to go in the direction I want to go.
I know. Protect yourself at all times, right? Yes. All right. So we're going to do speed dating. This is simple. You know all this stuff, but we're going to do speed dating because I don't know whether everybody else does. And there were some in here that I didn't know. So the quick speed dating is defined for us. Vinci.
The Da Vinci project is a project under HL7. They're a FHIR accelerator that focuses around payer use cases, specifically things about payment, prior auth, that kind of thing. Also exchange between payers and clinicians.
How widely used today?
Very widely used. Because it has been backed by the payers from the beginning, so all the health plans, literally almost every health plan in the country has put their voice in it. It's being very widely used wherever payers are using FHIR. And payers want to use FHIR as much as possible because of the Da Vinci, because they get the information. As I was told, well, a year and a half ago now, it costs the average payer $50,000 to get a CDA feed into their building. It costs almost nothing to get a new FHIR connection.
Yeah. I saw that in the notes there as well. Okay, bulk FHIR.
Bulk FHIR. Basically, if you're looking at a population health or other large amount of data you want to get, you get FHIR, but it's formatted in something called new line delimited JSON. So it takes the regular JSON and makes it one line per record with a new line delimitation, hence the name. And so if you're getting 1,000 or 10,000 or 100,000 records, you can do that without having to make a million calls, which come paged, 20 or 50 at a time. Yeah. What that also requires is asynchronous. So FHIR, by its very nature, is synchronous, right? Point to point, on demand. To do 100,000 records on demand would break every system there is. So there is such a thing under FHIR called asynchronous, which uses a very standardized system. You submit your query, it says, gives you an accepted code. So rather than yes, here it is, it's accepted, and then feeds back. It will check this endpoint for status updates. You then start polling that as often as you see the need, once a minute, once an hour, and then it'll eventually say done and give you the URL to download those blocks of FHIR. So you get one file, as large as it is, of all the information all at once. Not a lot of systems support it because there's a fabulous computational cost to this. I've talked to a number of the vendors and they're saying, we would have to set aside whole new installations at a hospital just to handle bulk, because it's anything you can query for, you can query FHIR. So if I say I would like everybody who has diabetes mellitus, who was born between 1965 and 1995, who live in Los Angeles, and your Los Angeles hospital, that's a legal bulk query. But if you try to do that, synchronously, they'll just laugh at you and hang up. But asynchronously, again, they can come back and say, okay, well, that'll take us 24 hours to generate. Come back in the morning, we'll give it to you. And you just start polling starting at 8 o'clock and get the data. because if you need that, immediately, your business case is broken. You really need to deal with your setup.
So you said it's not widely used at this point?
No, because of the computational requirements. It is in place. The standard is there. People have implemented it, but it's not widely used because it just is hugely expensive computationally. It would break an average Epic or Meditech or Cerner installation if they got 50 of those within an hour,
Oh, yeah.
where,
Yeah.
and most people don't need that level of data.
Right. Okay. Gravity.
Gravity gets you down. Next. No, the Gravity project is a FHIR focused on SDOH, social determinants of health information. They work to try to bring a standardized vocabulary around that, because there are so many services around the country of different types, of different sorts, that it's really difficult to get them all together. And until the Gravity project was created, nobody really had done a good job. California has their own code system, the 211 code system, that did a lot of the work, and many places inside and outside California use that. That became the basis for it. It was and put into the HL7 FHIR terminology. They've also put together some FHIR IGs on how to use it and how to bring it into other aspects of care and treatment, which, SDOH is being shown as being something that needs to be dealt with the way that hospitals and care organizations never did before. So having a terminology and having use case defined, FHIR profiles makes that so much easier.
And again, how widely used across the world, the nation, whatever?
But around the world, not so much. In the country, it's being adopted very quickly because it addresses something that is known. I mean, it's a huge issue. It's been recognized by ONC. It's been recognized by every provider organization that SDOH affects care. If we're going to do this, we need to take care of it. So the Gravity Project, while they're all volunteers, they have done some amazing work, and the country's recognized it.
Fantastic. Excellent. Well, now the other two that I had for you are Smart on FHIR and Fast FHIR. You've already touched on a number of those characteristics. One characteristic of Smart on FHIR, because that's predominantly what is out there today, at least in my world, it is. There are actually two elements of that. One is when you say Smart on FHIR, and where I'm kind of going with these things is, we hear these terms, and for those of us mere mortals that don't deal with it all day long, when we say that, are we talking about the security aspects of it, or are we talking about a Smart on FHIR app, or both?
Both.
Okay.
Let me break it down. So
Please.
There are two aspects to Smart on FHIR. There's Smart App Launch and there's Smart Backend Services. Smart App Launch is for really embedding an app inside an EHR or other healthcare system. So, and what that does is exactly what I talked about earlier, right? You get that client ID and you hook up together, and that allows for a clinician or patient to have a specialized application, a portal, a way of data, and hooked right into it. So it's very transparent, it's very clean, it's very simple, that they can get the information the way they want it, the way they need it, query for it. And that uses the smart security, both Smart App Launch and Smart Backend Services. Backend Services was really designed around two systems to talk to each other. Because if we're going to have an Epic and a Oracle system talk to each other, they need to be able to connect in a secure way and set the scope of comments. So they took that, and way back, it was created around the idea of bulk. Matter of fact, bulk FHIR was the same FHIR IG as Smart Backend Services. They snuck it in there. And means they're using system scope. So rather than saying, when you do Smart on FHIR app launch, you're usually restricting it to a specific patient or a specific user's access, right? So, a specific patient, Dave Pyke, I want just his data. Or I'm, Dr. Bob, I want all access to all the patients that I have. And those are scopes, patient and user scopes. When you're hooking a Cerner and an Epic system together, you want system scopes. So they're not restricted by user, they're not restricted by patient. They're only restricted by what types of things they can ask for. So I want to get all patient data. So, all conditions and observations and medications and encounters and blah, 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 blah. And they'll be scoped out that way at the system level. So still has that manual stage. They still have to contact each other, get that client ID. But then once they've done that, they go through, they do authentication authorization flows, and away we go.
And Jim, I'm going to let Dave take a break here for a second. I'm curious to pitch a question over to one of our other attendees. Michael, are you still around? It looks like you're still on. So I know Michael is works with digital solutions for Sutter Health. And Michael, you and I have often talked about the fact that, there's stuff happening in your organization as it relates to things like Smart on FHIR. So just curious if you've got a good example of a use case in the real world where you guys have leveraged the Smart on FHIR apps or other Smart on FHIR stuff.
Yeah, good morning, everyone. In the Epic world, they actually have a catalog of applications that leverage Smart on FHIR. They call it Showroom. It used to be App Orchard or Vendor Services. They've renamed it multiple times, but basically it allows for third-party vendors to implement Smart on FHIR applications directly in workflow with context-based SSO to launch out to a third-party platform. So we have several of those internally that we use today. One of the ones that I individually built, and we won a class award, which is why I'm highlighting it, was we built that for a genomics viewer at UC Davis, where we were actually able to, in context, launch out and view genetic results that Epic couldn't file discretely in a flow sheet view for variants of discrete and non-discrete significance, and leverage that whole Smart on FHIR context to custom build an internal application that didn't require our staff to log out or log into a different application inside of their native EHR workflow, which is Epic. They were able to push a button and essentially in context pull up the capabilities that are available for the application that we built. And I think that that's really most of what you'll see in at least the Epic ecosystem and probably others, which I'm aware of but not as familiar, is that in context in a particular workflow where you want to enhance or abstract from what Epic does and provide that capability to an internal user without any additional special effort and in context. It's kind of the old school CCAL stuff. That's where we see it. So I would tell you, I can look it up, but we probably have 25 to 30 vendor services applications that are tied into Epic through that Smart on FHIR launch point.
So, Mike, you're a pretty advanced user. I know I've listened to you talk with Marilee on office hours multiple times, and other things. You're pretty advanced with that and got a lot of things. Would you say that's the case across the nation?
No, I mean, this you get to is FHIR working or not, and I think the work that us is doing is, and I think back to Dave's statement, and I understand what the context in which he's saying point to point is. Most of the security and credentialing and authority or authorization around FHIR-based exchange is set up as an application to a particular organization and their technology stack, whether it's an EHR or middleware that's provisioning that. So it's widely adopted. If I were to pull my report, I would tell you that we had, north of 150, 200 resource calls across 30, 40, 50 apps that called 400 to 500 million resources over the course of the last month. And that doesn't include Epic's move on their care everywhere document exchange to documents on FHIR. So inside of Epic, they're actually even leveraging FHIR for document-based exchange. So that shows up in my API report, which I'm taking out of those counts. So it's widely adopted as a standard. Where the failure is or where the gap is today is intra-organizational application exchange between two different parties that aren't part of the same organization, and then how they share that security protocol and connect those applications in order to facilitate exchange. You'll see an example of that with eHealth Exchange has a project called Trebuchet that's for electronic prior auth, has created kind of a marketplace feel for the ability to do electronic prior auth through a marketplace using FHIR. But there's not a lot of networked FHIR type of projects that I'm aware of out there. And again, we talked about TEFCA and kind of the move to that basis to allow for, directory discovery, security, trust, all the things that are required to actually open up your endpoints for that exchange. And I know I heard you talk about, I had to drop for a second, but I heard you talk about Epic, the whole issue or the whole access provisioning with the client ID. That's actually Epic's internal security protocol that limits the number of FHIR resources that you have access to. So your client ID is kind of the key to the FHIR resource kingdom. So your client ID, Zen's client ID might have access to the patient resource and the meds resource and the document resource, but Dave's custom island-based application only has access to lab results, right? So, and that's tied to the client. The security is tied to that client ID and what resources are available. So that's how Epic manages that access internally.
I'm so glad you made the reference to the background. I think that was perfect. Thank you.
Well, I mean, I'm just surprised that the hair gel's holding through this 45 minutes. So, I think Dave needs some product placement sponsorship on the next webinar he does, because whoever's got that hair gel has definitely done a great job.
It's
Because I don't
Gorilla
have that.
Glue.
I obviously
I
don't
don't
have
use
that
anything
problem.
less.
My problem is the light is shining off of my. I need some powder or something for my forehead. So
Yeah, because the sun is behind you, yet the light is shining on your forehead. It's a little
Exactly.
weird.
It is.
All
I'm in
right.
the vortex. I'm in the Project Hail Mary vortex or whatever. Anyway, so I'll leave you alone, but I'm happy to be summoned at any point if there's something I can be helpful with. Not to interrupt Dave and your all's flow in this, but hopefully that was helpful.
It absolutely was, and thank you for contributing as to the way these things work. But you guys have completely blown my my outline here entirely, because I
Yeah.
did
Again,
want
if
to
you
say,
don't tell us in advance, you get what
I
you
know,
get.
I know, I thought I was going to be in control. I should know better.
How long have we been married?
I know, long time. It was foolish. I keep hitting my thumb with that hammer.
5 years? Only 5?
40. Sorry, that was a 10. 4,
Oh,
0,
okay.
and then
Yeah.
plus 1.
Yeah.
Okay.
41. Anyway, we got 12 minutes, and I'd like to reserve some time for Q&A. But before we do, we've talked an awful lot about, well, no, as Mike was just talking about, where things are today. Pretty advanced, pretty good. It's entrenched and it's working.
Yeah.
But as you mentioned, Dave, at the very beginning, and I think that there is a quote, something that about roaches and the HL7v2, something it's attributed to you. I won't go into it or necessarily there, but my point is that most everybody on this call has one foot on the boat, one foot on the dock, and because it isn't adapted overall, CDAs are still alive and well. 98 or some percentage of that data that's going through the national networks is based on them. HL7v2 is a long way from dead. We even haven't even talked about the use cases where, okay, if I'm querying for data, that's great, but if I'm pushing data back in, Marilee, you can give a lot more color with regard to the use cases for that. How do we go from where we are? How do the people that are on this call live in the world where we've got that one foot on each of those entities and do that for an extended period of time? What's going to happen?
Right now, everybody's limited by the G10 requirements. Right, the certification requirements issued by ONC, G10 is FHIR. Well, sorry, it specifically says APIs and then says FHIR, which mandates the use of SMART, which when it was written is perfect, right? That's been around since 2021. It's, as part of I think the nth revision of the 2015 versions and all of that. And that was fine. But again, the only problem with SMART is it doesn't scale easily because it has a human step. Now that we're seeing the national networks embrace FHIR, right? Care Quality did it first. TEFCA is the one who's going to bring it to fruition, because by the end of Q2 next year, everybody using FHIR on TEFCA, and that will be voluntary, but everybody using FHIR on TEFCA will be using the Fast Security Guide, SARA Guide. That means that finally we will have a standard that scales, that doesn't require intervention, that doesn't slow down because, oh dear, I need to connect to another hospital across the country who won't automatically say yes because I'm in their state or city. But if I'm in New York and I want to connect to a hospital in Nebraska, they don't know who I am. They don't know as a user. They're going to do a lot more risk analysis. That slows things down. With TEFCA, once you sign on, right, you've got all these agreements that everybody's agreed to, the terms of participation, which are embedded in every participant and sub-participant contract, saying you're going to be a good person and you'll follow good practices for exchanging information. Once we have that in place, then it's just a matter of, okay, hey, I've got a cert. I'm from New York. You don't care, right? I've already shown I'm a good person, or pretending to be. I go to Nebraska Hospital. I go, let me in. I've got a cert. This is who I am. This is the information you need to let me in. And they say, sure, get that information. The benefit is that works for push as well. Right now, 90% of all FHIR is pull. 90% of all data exchange is pull. But we need to be able to push things in, whether that's appointments or, hey, I want to report all the information from my smartwatch to my doctor, who will, of course, look at it very closely and read each reading as it came in every minute of the day. They won't just aggregate it and then delete it. We need to get push involved. And because the Fast Security IG does do that, it not only goes to, hey, I'm going to be a good participant in this trust framework, it also can say, hey, this is who I am. This is my use case. This is all kinds of additional information. No, we do not want to put facts in anything. We want to put facts in the wastebasket. Michael, you are fired.
Okay, but I'm going to interrupt you because we got limited time.
Okay.
What you're talking about sounds wonderful.
Firing Mark? I think so too.
Yeah, right. And the palm trees and the breezes blowing. But the reality is that no one. I'm taking this to an extreme, but bear with me for the point. No one is from the C level is making the decision to invest in that today because not everybody else has it. There is a critical mass characteristic that once critical mass, whatever that is there, and all of my other people that I need to talk to are doing it, I will do it.
Yeah.
But everybody's waiting on everybody else. What defines, how do we increase that critical mass? Because people like me, okay, I got to make the decision to invest in it today, and yet it's not widely adopted.
And that's the thing, right? As Epic is moving all of their people off their other national networks onto TEFCA, as Cerner is going to do the same thing. And they're all, and the biggest thing is payers. Payers want FHIR. Payers do not want a CDA. If you give them one, they'll frown at you. And the minute it's like, oh, payers start getting on, and they're starting to look at it very carefully. I'm told one is actually in the process of signing up. If we get the first one on, then we get 2, then we get 5, then all the payers are on, and we all sit back and go, job well done. Let's go to the beach.
And Dave, don't you think to we've certainly seen a lot of discussion around this, that to the extent that people are going to have a foot in each camp, that having tools that will do transformations between CCDA and FHIR, so that, the network today is going to give you mostly CCDA, and a year from now is going to be 80% CCDA and 20% FHIR, and that, right, we're just going to have this blended approach for an extended period of time. Those kind of tools would seem to be pretty important.
Absolutely. FHIR supports documents, right? You can create it, so it's called a FHIR document. It's just a bundle of FHIR resources with a table of contents resource in it. It's not actually called a table of contents. But for now, being able to convert all that historical data, because if you're in an HIE, if you're in a major provider, you have 10 million CDAs lying around that all need to be converted. There is an HL7 FHIR CDA guide that can help you do that. But you're going to need somebody to take all that wonderful data, whether it's CDA or that repository of V2 messages that you've been sitting on for the last 23 years and don't know what to do about, and convert it to FHIR resources, which are useful. But there's a huge problem with that because in V2 messages, and less so, but still a problem in CDAs is semantic problems. There wasn't tightly scripted who's going, which terminology you're going to use. SNOMED, ICD-10, all of these, and then you add on top of that so many private. Hey, in our hospital we have these codes for this. Nobody else uses that. That's okay. Those all have to be mapped. It's a nightmare because we've been doing interoperability badly for 35 years.
Right.
It's time to do it well. It's time to let the CDAs go by the wayside. I know you all love them, so we all do. We all grew up with CDAs. It's time to kill them, take them out behind the shed, and shoot them.
There's a question in the comment, and I want to grab it real quick. I think it's a good one. Harsh says, why is there such a cost difference between payers accessing data via CDA versus FHIR? Dave, you gave the $50,000 example.
Yeah.
And the biggest one is semantic interoperability. The nice thing about the CDA standard is everybody implements it differently. So although there is a structure to it, there's all kinds of information in there, they're not, unfortunately, 100% standardized. NIST maintains a tool to test a CDA for compliance to the CDA standard or the CCDA standard, and many still get less than a B if you submit a vendor CDA to it.
Oh, yeah.
And that means human work. That means coding to deal with the fact that they're using custom code. Oh, okay, we have to map that custom code to, whatever code system is appropriate, whether it's SNOMED or whatever. All of this doesn't happen because in FHIR, it's very tightly bound, right? In a patient, in a condition, it's bound to ICD-10 or to LOINC or to SNOMED or to blah. So you're not sitting there, okay, this code is QZ438. I have no idea what that is. And the hospital doesn't remember what it is, but we've got 2,000 records with that code in it. What are we going to do? That's money. And there's nothing else we can do. Oh, look, we got rid of Michael Marchand.
We ran him off.
We did. We got another hand up as well. Dennis, I'm going to make you go fast because I got 2 minutes.
Real fast, and we can take it offline perhaps. But my question is around this transition problem. In the jungle, I've got to hold on to the old vine while they grab the new one, the next one, right?
Yep.
So it plays off what Marilee just asked and what Jim said a few minutes ago. What about using AI and RAG for that transition for the
He said the naughty word.
The messages from V2 to FHIR or from FHIR to V2, depending on what I know how to consume and what I know how to send. So what are your thoughts and any evidence that it's being done anywhere?
Again, AI is a wonderful concept.
Dave, just say yes.
Yes, Dave. No, don't use AI yet. The problem is that for semantic interoperability, AI just isn't going to be there for dealing with. If you want to summarize a clinician note, it's fine. If you want to categorize a clinician note, I'm still not sure that you won't get 20% hallucinations, which means that patient's record just became garbage.
Yeah.
So I did put a note. I was doing a little bit of a commercial there, but I just think it's such an important problem. We need to make people aware. Zen did build a FHIR to CCDA converter bidirectionally. It is quite good. We have Jeff Cardenas on the call who led the development effort on that project. Woohoo, Jeff. So for anyone who wants to learn a little bit more about how we did it, we'd love to chat with you. So just let us know.
Absolutely. And I would have been disappointed if you hadn't said that, Marilee, because we got to sponsor these things. It's great. It is the top of the hour. We do end on time here because we respect everybody's time. Dave, Wonderful. Thank you. I hope that you will consider being abused or abusing us again as the case may be in the future, because there's a lot more to cover here. I'm sure everybody is very grateful as well, even though they don't have their microphones on. But collectively, thank you very much for
Lots of good comments, though.
really great stuff. And
Thanks for inviting me.
yeah, absolutely. We'll let everybody go. We will be posting this out and getting the links out. Sign up for the next one as well. Karen put the link in there. We'll find some other knucklehead that is crazy enough to come join us.
Wait! I've been insulted.
Oh, I'm sorry. We'll have
But
some
Dave,
more fun.
next time you can just show up, and then you can be the person
Abusing.
jumping the chump, as we sometimes like to call it. So.
Thank you for joining.
Everybody.
All right.
Thank you.
Thanks, everyone.
Everybody.
Bye.
Have a great time. I'll see you next time.
See you next time.